My name is Wendy. I'm the inventor of the WristWidget. And we manufacture the WristWidget in Hawaii in a zero-waste facility, fully powered by the sun. It's an honor to be here today to talk about the TFCC, and it's really great to see so many people having this discussion. Since 2006, we have touched well over 1.5 million wrists. I'm hopeful to share with you the lessons that we've learned in a very short 12 minutes. The TFCC is a lot more prevalent than we ever imagined. Most people on the planet don't have access to our care, and when they do, it's often really delayed. Conservative therapy should be the first line of treatment for anybody with ulnar-sided wrist pain. Surgical management should be saved for a very small percentage of the cases we see. This is a very disabling injury. I've never had so many people scream so loudly about their wrists. Early intervention is essential. Early diagnosis is really important. There is a huge level of conflicting information that patients receive from us, and we have a lot of work to do. What we do is everybody that comes to our site and orders a WristWidget, they get a questionnaire. How'd you hurt your wrist? Where does it hurt? What's your weight-bearing numbers? What's your function? What treatment have you had? And so we're able to look at thousands, 45,000 cases we've collected data on, and the growth of those numbers are exponential. So we get people that are willing to share their MRIs, their x-rays, their doctor's reports, their op reports, their therapy reports. So we see not just people in our area, but people around the world. We're able to take these surveys from every continent. It's astonishing, really. And we have the luxury to follow them over the course of time to see how they're doing in 3 months, 6 months, a year. Biggest question is, what does the WristWidget do? Take a look at these x-rays. Look at them closely. It is well known that ulnar variance is an issue with TFCC tears. If the TFCC is the load-bearing tool that you have in your wrist, when it's torn, you get a spreading of the distal radius in the ulna. And that spreading makes it look like you have a positive ulnar variance. On the left is a wrist. This was sent to me by a physician in Taiwan who was brave enough to take the x-ray with and without the WristWidget. On the left is without the WristWidget with a positive ulnar variance. On the right is the same wrist, same day, same time with the WristWidget on, and what you see is the ulnar variance changes. What the WristWidget does is it takes the radius and the ulna and it squeezes them together without compression to the ulna head. And if you take those two bones and you hold them together, allowing rotation, allowing wrist extension, and you keep it in there for a period of time, the TFCC heals. The TFCC heals. That's what the WristWidget does. We have all these fantastic tools, x-rays, MRIs, CT scans, clinical exams, exquisitely trained practitioners that are looking at the wrist, and yet the TFCC is very elusive. It's very difficult to get an agreement of that X-ray shows this and that MRI shows that. And we see this all the time. We see people that show us their X-rays and their MRIs and the doctor's interpretation. They take that same information, take it to another doctor and get their interpretation. The interpretation and the understanding of how to diagnose a TFCC is really bad. It's really bad. You cannot see a correlation between somebody, there's false positives and false negatives all the time. We need to do better. So I started testing in 2006, knowing this, that we needed a tool to test the wrist. And that tool is a non-digital scale. How many of you have a non-digital scale in your office? Oh, yes. I feel like taking this thing and whacking it across. This is the most valuable tool in understanding the wrist. It has to be non-digital. It's available everywhere. Simply, you place the scale on the table, hand flat, long finger at 12 o'clock, elbow straight. You push down as hard as you can and you stop when it hurts. The normal weight bearing of the adult human wrist was described. I went around and gathered normal weight bearing in a large population around the world, and we know that weight bearing is the same on the dominant and non-dominant wrists. Right and left is equal. We know that it's based on age, height, and sex. The taller you are, the younger you are, and if you're a male, you have very high weight-bearing numbers. We know that it goes down with the course of time. So in this study that I published, the average of weight-bearing tolerance in the adult human wrist is 70 pounds. You should get to know this. We know that most people's grip strength is about 15% less than weight-bearing tolerance. This is important. If you see somebody that has more grip than weight-bearing, it is a clue to something else. Bone density, we can pick out people with bone density issues when their weight-bearing bilaterally is really low. The only injury that behaves with a loss of weight-bearing tolerance, so it hurts to put weight on it, but when you wrap the wrist with tape, non-elastic tape, or the WristWidget, and that weight-bearing goes up, you know you have a TFCC tear 100% of the time. In a normal wrist, if you squeeze the distal radius and ulnar joint, the weight-bearing goes down. If you have a fracture, the weight bearing does not change. If you have an ECU only tear, the weight bearing is pain-free and normal. If you have a UT tear, the weight bearing is normal. If you have a nerve injury, you see all sorts of things, but you need to see a change in the weight bearing numbers with the WristWidget on or non-elastic tape to accurately define the tear. We have also learned that the weight bearing is a predictor of what they can and can't do. We need 45 pounds of weight bearing to function. If you don't have 45 pounds of weight bearing, it hurts to do everything around the house. You need 65 pounds, probably 60, to load the wrist. If you have under 20 pounds of weight bearing, you have an unstable, very concerning wrist that will cascade predictably. It'll cascade into ECU tendonitis and subluxation. It'll cascade to scapholunate problems, flexocarpal ulnaris problems, ulnar nerve problems. So if you have somebody with under 20 pounds of weight-bearing tolerance, you're in the red zone, and they need really close monitoring. That took a long time to figure out. The weight-bearing protocol is based on their starting weight-bearing numbers. How long does it take for TFCC tear to heal? It depends, of course, if it's a mild tear, a moderate tear, or a significant tear. And there's different things you have to do. You want to get, if you have a severe tear, you shouldn't be strengthening. If you have a significant tear, you have to protect the wrist. You've got to do a Munster cast, a wrist splint at night. But again, you have to keep those two bones together. If you have a TFCC, you need to keep them together and hold them there for a period of time. These landmarks are really important. So if you're under 20 pounds, red zone, protect the wrist, consider the casting. Monitor very closely, no strengthening. 20 to 45 pounds, you're almost over that hump. You know that your wrist is non-functional, you shouldn't be loading it in the house, you again should be protecting it. Once you get to 45 pounds, you're good. You've passed that big hump of function. So now you don't have an unstable wrist and you can function. You can't load it, but you can function. Get to 60 to 65 pounds, now you're ready for strengthening. Now you're ready to start testing. We start strengthening at 45 of the proximal muscles, but we do not do any strengthening because we find that the strengthening makes the ECU, tendonitis, scapholunate. We tried a large variety of strengthening programs, and we don't do any strengthening of the wrist until you're at 65 pounds. Distal strengthening and re-education is very important. We don't do that till the very end. I don't have time to talk about the details of this today. If somebody's in a Munster cast, there's a period of addressing the elbow that's really important. After that, you really have to focus on tricep strengthening, ankles, end range elbow extension. The effects of the Munster cast can be significant on that, and the superficial branch of the radial nerve often is affected with the Munster cast. So pay attention to those. So it's really important to have weight-bearing numbers because you can see the cases, the types of tears that just really need to have a surgical intervention. And those, when you look at those, the under 20 pounds of weight-bearing that don't progress, you want to see a steady progress every week. And if you're not seeing that, at some point you have to make a decision quickly. So getting that person from 20 pounds to 5 pounds is you got to watch them closely and move it along. Cortisone injections are very interesting. What we find is that when you inject the wrist with cortisone, the weight-bearing tolerance goes up falsely for 14 days. So the patient goes from an unstable wrist, but now doesn't feel pain and can push down, but then it plummets at the end of 14 days. So if patients are getting cortisone, don't do anything on that wrist for 14 days. No strengthening, you protect it and let it rest so that that plummet after that 14-day period doesn't harm them. We have a Facebook group that now has 9,000 members. And if you want to see what a terrible job we're doing, go take a look at the Facebook group. The surgical complications are devastating. Devastating. And to look at 9,000 people in a given day and read their reports tells me that we've got a lot of work to do. It is our goal to diagnose these cases early and to give them the tools to treat this so they don't have to go down that road. Now I know, you know, and that really makes me happy. If you guys have any questions, I'm reachable anytime. If you have patients that you want to enroll in a study, good cases, send them our way. And stay tuned for more changes in the way we manage TFCC tears.